Hi everyone. Welcome to today's webinar. We're gonna get started in a minute or so. We're just gonna give everyone a little bit more time to log on. All right, we're gonna get started. Hi everyone. Welcome to the webinar, Strategies for Managing Recurrent Ovarian Cancer. I'm Maggie Nicholas Alexander, the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Westin finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now, Andrea Herzberg, SHARE's Ovarian Helpline Coordinator, has a few words to say about the significance of today's program.
Hello, everyone. I was lucky enough to meet Joan in the late 1990s when I joined SHARE's, pretty new at the time, ovarian cancer support group. When a support, as many of you know, when a support group works, it works. We cried, we laughed, we talked about little things, we made small talk, and we definitely made large talk. Joan was a nurse diagnosed with late-stage ovarian cancer, stage 4, as a matter of fact, during the birth of her third child. Of course, it was devastating, but Joan became determined to live, to raise her children, which she did, along with her wonderful life partner, her husband, Joe. Joan was smart, funny, daring. She became a very effective advocate, and she inspired many of us in the ovarian cancer community and continues to do so today, inspiring us to live our best lives, whether we're no evidence of disease or in prolonged treatment. This is the 6th annual, as you heard Maggie say, the 6th annual Joan Sommer Educational Program, and we always aim for topics and for speakers that we think Joan and her family would have loved. Last year, it was about the how, when, and why of taking treatment breaks, and today, strategies for recurrence. Joan participated in clinical trials, and she and Joe made sure they had great communication with all of her doctors, and that they themselves, Joe and Joan, understood promising research and realistic options so they could make informed medical decisions. I know that right now, Joan is smiling and applauding your being here with us today. Back to you, Maggie.
Great, thanks, Andrea. Now I'd like to introduce our speaker for today. Dr. Westin is a gynecologic oncologist and clinical investigator at MD Anderson Cancer Center. Dr. Westin focuses on developmental therapeutics and the use of biomarkers to predict response and recurrence in gynecologic malignancies. She currently serves as the Director of Early Drug Development and phase 1 trials in her department and is a co-director of the Ovarian Cancer Moonshoot. In addition, she is currently the PI or co-PI for greater than 20 novel treatment trials in gynecologic malignancies. She serves as a co-chair of the GCSC Ovarian Cancer Task Force and the NCI Ovarian Cancer Clinical Trials Planning Meeting. As such, she is guiding development of future NCI trials designed to push the field forward and expand the role of precision medicine in ovarian cancer. Great, thank you so much for being here, Dr. Westin. I'm going to turn it over to you.
Thank you so much for having me. I'm seeing maybe that you guys are seeing a clear slide. Is that true? We had this happen earlier. Shoot. Okay. Give me a second. I am so honored to be here, and I'm so sorry that my slides are not doing what they're supposed to do. Just fiddle it for a second. It's one of my favorite things to do, to talk to ovarian cancer survivors and their family members, because I think that it is one of our biggest opportunities to make sure that you all know exactly what we're doing, and that that you know what's out there and what's coming next. So I'm going to spend the next 40 minutes or so talking about what we're looking at in ovarian cancer and what things have been being explored and what things have not done well, and what things, mostly focus on some successes today. And as mentioned, I am an associate professor at MD Anderson. These are my disclosures. I do a lot of drug development. I work with clinical trials, and so I'm very honored to have a number of industry partners that help us bring new drugs to you all. For the objectives of our talk today, we're going to talk a little bit about just some basics of recurrent ovarian cancer. What are the options for patients that have been so-called platinum sensitive, and what are the options for patients that are now platinum resistant? And we'll talk a little bit about some of the problems with those names or those titles, but still we use the nomenclature that we can. And then I'll talk a little bit about how we might avoid chemotherapy in certain parts of our treatment continuum for recurrence. And so I think hopefully it'll cover a lot of ground and stimulate some great questions. So first, let's just talk about ovarian cancer recurrence. So what we know about ovarian cancers, it really does seem to be three biologies. We have a population of patients for whom they recur almost immediately. And those patients, their cancer comes back during either treatment or right after. And that's called primary resistant or refractory to platinum. Then we have another population which their cancer comes back, but it takes some time. It takes some years, and usually it's anywhere from 6 months after the completion of therapy upwards of years and years. And you know, we often get asked, and I know this is especially important to those of you in the audience, is, well, when am I really free? When am I free of disease? When can I truly relax? And the answer is, you got to relax right away, because this is a marathon, not a sprint. You know, we all have patients that have gotten past 5 years and 10 years and still do have that cancer come back. It's rare, but it's there. And so I tell people, just start living your life, when you're off of treatment or when you're on it, and just move on, because there's no real time when we can say, okay, this is done. Now, I do, with that being said, if we get out to 5 years or so, I do start feeling really good. And I tell people, you know, this is as close to a cure as we can get, but we still continue to monitor closely. So what are we thinking about when we have someone that has had a progression in their disease? How are we going to make decisions about what to treat them with? And this is that whole idea around platinum sensitivity that I was talking about. Really what we're trying to move toward is treatment-free interval. So how long has it been since you were on treatment? How much time has passed? Because that gives us a sense of what things might work for you. We also look at things like residual toxicity, how much cancer is there when it comes back. Is it only your CA-125 level, or is it that we can see something on the imaging? And then how can we maximize quality of life? And what are your goals? What are you looking towards? Obviously, our goal is to live, but sometimes we have to also set smaller goals. Okay, I want to make it to this graduation. I want to make it to this event. Those are the things we need to consider as we're determining what treatment is best for you. Now, I talked about treatment-free interval, and we often lean on this so-called platinum-free interval. You were treated up front. You had surgery and chemotherapy. It included a carboplatin-based therapy. How long has it been since you have had that platinum? Because what we know is the shorter amount of time between the end of treatment and the recurrence means a less chance of response to, say, standard therapies and especially platinum-based therapies. We are moving away from that whole platinum sensitive, platinum resistant, although you will see those names in my talk, and trying to get more, is this appropriate for, is this a patient who should receive platinum again or not? What's the chance of getting benefit? So I give you this information, these last few slides, just so you kind of know where things are heading. And if you're looking at websites and research, you understand kind of what they're getting at if they're not using those terms of platinum sensitive and platinum resistant. So with that being said, let's talk about options. So if we think platinum is a good option, what are we going to do? The bottom line is that we're going to use a doublet therapy, which means 2 treatments, 2 chemotherapies, and they're platinum based. So they're going to have a partner with carboplatin. And this can be paired with a number of different other chemotherapies, including paclitaxel, pegylated liposomal doxorubicin, or gemcitabine. Now, the pair doesn't matter. What we know is you want to pair over carboplatin alone. That's where we get our benefit. We have people living longer, and we have people having better quality of life. Now, we also have explored using targeted therapies in addition to this so-called doublet therapy. So bevacizumab is a drug that's been looked at quite a bit in ovarian cancer, and I'm sure many of you are familiar with it. This is a drug that targets the abnormal blood supply of the tumor and can target the tumor directly, and it plays really well with chemotherapy. And so what we found is if we give a platinum doublet, but we add bevacizumab, we again are living longer, okay, and we have better quality of life. And it sounds like somebody's car alarm is going off, so just excuse that. So here are the data. I put them all together so you could see the 3 major trials that have been reported that have looked at adding bevacizumab to one of the doublets. The OCEANS trial utilized gemcitabine and carboplatin. The GOG 213 trial used paclitaxel and carboplatin, and the NGOT OV18 trial used pegylated liposomal doxorubicin and carboplatin. And then all 3 added bevacizumab, and consistently across all 3 treatments, we saw an improvement in progression-free survival. Now, these curves, you're going to see tons of curves like this in this talk, so I just want to take a quick side note to make sure we're all on the same page of what do these curves mean. So if you look at these curves, the bottom line is time. So the longer to the right it goes, it's better a longer amount of time. And an ideal curve for survival would be right across the top, 100% survival. It's obviously not what happens. We do have patients that pass away or have a recurrence depending on the outcome we're looking at. And so we see these curves. As the curve goes down, those are people that are having recurrences, okay? So how do we tell if one treatment's better than the other? Well, we map both of those curves and we want to see a space. So one of my favorite teachers used to tell me, if you can put your thumb between the curves, that's a positive, okay? So you don't need any statistical test, just use the thumb test, okay? And we're gonna see some curves that are prettier than these that we can actually drive a truck through, okay? So that's when we know we're getting really great outcomes for you guys, for the patients, okay? But the bottom line for bevacizumab, the bottom line for this anti-blood vessel drug is that it can improve time without recurrence, progression-free survival, and it seemed to improve overall survival in a population as well. So that's obviously a really great option. But many of you have heard about these newer drugs called PARP inhibitors. And so there's an option as well for patients that may benefit from platinum to use, again, that platinum-based doublet therapy, but instead of just stopping therapy at the end, or instead of being paired with bevacizumab, you can use a PARP inhibitor. And so this is a schematic of the trials I'm going to show you. I'm going to show you 3 big trials in the next few slides. They all look very similar. They just have different drugs, okay? But they all are PARP inhibitors, which work on the way our cells repair their DNA damage. And so these trials enrolled patients that had had chemotherapy at the time of their recurrence and had a benefit. They either had a PR, which is a partial response, or a CR, which is a complete response. And then they were randomized to continue either the PARP inhibitor alone or a placebo. Okay, and they continued that until their cancer came back or they were unable to tolerate that. And they looked again at progression-free survival as an endpoint. How long could the patient stay on without their cancer coming back? And what they found, so we've got 3 major drugs, we've got 3 FDA approvals here. This is a very exciting time for ovarian cancer. We've had so many great things going on. Okay? So how did we get these drugs available to you? The first trial was SOLO2. SOLO2 was a trial of the PARP inhibitor olaparib. And again, it had patients that had a recurrence, had response to their platinum-based doublet therapy that we talked about, and then were randomized to PARP versus placebo. Now, importantly about this trial, this is a unique thing about this trial, they only enrolled patients that had a BRCA mutation. They had previously done a smaller trial that did show benefit for olaparib in an all-comers, regardless of their molecular abnormalities, regardless of that presence of BRCA mutation. But they did an additional trial per the FDA's request, specifically in that patient population that had BRCA mutations. And again, they were looking at progression-free survival. What did they find? They found, here, remember I promised you a Mack truck. This is more than a thumb. I can put really like dive through that. This is a beneficial treatment. Right? We see patients that got the olaparib living much longer without progression than patients that got a placebo. So this was a practice-changing study. And based on these results, as well as the results from the earlier trial I mentioned, they were able to get an FDA indication or an approval that any patient after response to therapy in that recurrent setting can get this option, can get olaparib. So very, very exciting. Now, the second trial that got an FDA approval in this space is the NOVA trial. Now, very similar to that SOLO2 trial we just looked at, except it was an all-comers population. Any patient that had a recurrent ovarian cancer that had had a benefit from their chemotherapy doublet was randomized, and they either got the niraparib or placebo, okay? And again, progression-free survival endpoint. And what they found, they looked first at the group that had a BRCA mutation. And again, look at this, that's that Mack truck space. So clear benefit from reducing the risk of progression for patients that got treated with the niraparib. And importantly, it went on for some time, for years, okay? So they got prolonged benefit, which was very exciting. Now, they did tease out other populations. So they looked at an all-comers population, patients that did not have the mutation. And you can see, maybe not a Mack truck, but a pretty great distance between those two survival curves, indicating that really any patient can benefit. It's just the patients with the BRCA mutation that benefit the most. But there's room to improve, obviously, but it's something we can do right now for you all as patients. And so this was approved back in March of 2017 in the recurrent setting for maintenance. And then last but not least is the Ariel 3 study. Now this study, again, all comers, high-grade ovarian cancer, recurrent disease, responded to their platinum-based doublet, and then were randomized to either rucaparib, the PARP inhibitor, versus a placebo. And again, the primary endpoint was progression-free survival. So you're going to see a theme here, and I think you're going to walk away learning something, because again, we saw the biggest benefit in that group that had the BRCA mutation, the least benefit, but still some benefit in those patients in the so-called ITT or intention to treat. That's the all-comers population. But what Ariel 3 did was they started teasing out another population, a population that didn't have a BRCA mutation, but they had an abnormality in their tumor called HRD, homologous recombination deficiency. And this HRD abnormality seemed to predict response or benefit from a PARP inhibitor. So that was really exciting because it gave us a bigger population of patients who really and truly benefit from this PARP inhibitor maintenance. So that was exciting. And this drug did get an FDA approval just a few months later, April 2018, in an all-comers population. So the bottom line is we've got lots of options, and PARP maintenance is the real deal. Okay, it's the real deal for everybody. It's the biggest deal for patients with BRCA, but even patients that have a completely biomarker negative tumor can still get benefit from this option. So that's awesome. But I know what you're thinking. What about when they have a recurrence? Is there something that we can do? If all these patients are getting treated with PARP inhibitors and their cancer comes back, can we do it again? I mean, can we retreat? And so this study is called the OREO study, and this study is looking at just that. So patients that got that PARP inhibitor maintenance and then get chemotherapy again, have a response. Can we go back to the wheel? Can we go back to the well and see if PARP inhibitors work again? So that's an exciting option for the patients. And then the second question is, well, Shannon, you just presented like 4 different things I can get for maintenance. You told me about bevacizumab, that anti-blood vessel medication, and you told me about 3 PARP inhibitors. So how do I decide? Well, obviously you're going to work very closely with your physician to try to pick the right thing for you. But these are some of the factors that I personally consider. Obviously, is the option indicated in your type of tumor? What is your BRCA status? Does your tumor have homologous recombination deficiency, that HRD? What are the toxicities of the drugs we're looking at treating you with? And what is already going on in you? Like, what side effects do you have right now? Do you have persistent neuropathy, numbness and tingling? Do you have issues with your blood counts that might make us pick something over another? Okay. The schedule matters, right? So bevacizumab is an IV infusion every 3 weeks. These PARP inhibitors are pills. Some of them are given every or 2 times a day. Some of them are given once a day. So these are the types of things that we work with. And then of course, cost matters, right? So the majority of these agents are covered by insurance, but that doesn't mean that they pay completely. We all know about copays. And so really balancing how much people are going to have to pay out of pocket. And certain drugs might be covered more by certain insurances. So those are all the types of things that we really consider when we're making decisions around maintenance therapy. So then the question comes, we talked all about these platinum doublets, right? Those are IV chemotherapies. They have their sets of side effects. So in this setting of patients for whom platinum is an option, can we avoid chemotherapy? And there's a number of trials that have been looking at that. So we're kind of going backwards here because before PARP was looked at as a maintenance strategy, it was looked at as a treatment. So you've had your recurrence and you have disease that we can measure, we can see on a scan. Can we just use the PARP inhibitor without giving you chemo first? So we have some data to support that. This was a trial of olaparib, which was a single agent given in patients that had a BRCA mutated ovarian cancer and it had multiple lines of therapy. You can see here on the left, the response was 30%. What does that mean, Shannon? That means 30% of women had shrinkage of disease, okay? Which obviously is very, very good. We'd like to see 100, but these patients often have gotten multiple lines of therapy, so that is a good outcome. And this was enough to give us an FDA approval, so we can consider PARP alone for patients that have a BRCA mutation. But we know that's only about 20% of patients, so there's a need to develop more combination options for patients that don't have that BRCA mutation. And it's important that it does seem to be related to prior lines. And so as patients get more and more prior lines of therapy, we see a reduction in that response to therapy. And that makes sense. Your tumor has become more resistant. It can avoid the typical mechanisms of a particular treatment. So that small study that yielded an FDA approval was then taken into a larger study to compare it to chemo, because that's what we want to know, right? Does PARP work as well as chemo? Is it my best choice? So this was a patient population that, again, had BRCA mutations, had several lines of therapy, and had measurable disease that we were treating. They were randomized to either olaparib or a number of different physician's choice chemotherapies, including things like weekly paclitaxel, topotecan, Doxil, and the like. And they were looking at progression-free survival. And interestingly, this was a very highly pretreated patient population. More than 50% had gotten already 4 lines of therapy. So the fact that there was activity here is super exciting. So these are all the endpoints that showed us that PARP was better than chemo. You can see on the top here, these little bars, that is the response rate. And again, like I taught you, that means shrinkage of disease. That's obviously our ultimate goal. We want the disease to go away. And what they found is in all patients, including patients that had more than 3 prior lines of chemotherapy, they saw shrinkage of disease, more shrinkage in the patients that got treated with the PARP inhibitor than in patients with chemotherapy alone. Now, these little falling plots, these are called waterfall plots. Waterfall plots are really cool. You want to see everything going down. Each bar is a patient, and it is showing how much her tumor shrunk. So look at these waterfall plots, just so cool seeing all those tumors shrinking. Very exciting. And then, of course, you'll recognize the survival plot over here On the right, that's again, how long did they live without their cancer coming back? And there is a space. It's not quite Mack truck. It's maybe a couple finger space, but it's still statistically significant and very clinically significant for patients. So that was really exciting to see all those data come to fruition. Now, olaparib isn't the only option in this patient population. Rucaparib also has an FDA approval for patients with a BRCA mutated ovarian cancer. And that was based on the Ariel 2 trial, which looked at progression-free survival and response rate. Look at this response rate. Almost 70% of patients that had that abnormality had a response to therapy based on shrinkage of disease. And that was really exciting and did yield an FDA approval. They also teased out a so-called BRCA-like group. That's that HRD test we were talking about. And they have a 30% response rate. So very exciting. But interestingly, the company actually didn't pursue this option for patients as an indication. So right now for rucaparib, we can only give it to patients that have a BRCA mutation. Now, niraparib, on the other hand, they explored that population of patients either with a BRCA mutation or that HRD positive tumor. And so this was the Quadra study where they did it in any patient that had 3 or more lines of therapy. They got treated with niraparib alone as a PARP inhibitor, as a single agent, and they watched again for shrinkage. Now this trial, similarly, look at that waterfall plot, right? We see falling, we see shrinkage of disease, and they saw that in about 35% of patients. So that was really, really exciting. And so niraparib is an option not only for patients with BRCA mutations, but also for HRD positive disease. So pretty cool. Now, remember we talked about all this stuff is for patients with BRCA mutations, right? And for people that don't have either the BRCA mutation or that HRD tumor, which is about 50% of patients, they're kind of left like, well, what do you do for me? So there have been a number of combination strategies that are under evaluation for that very person. Okay, so GY004, this was a study combining a drug called cedarinib, which is similar to bevacizumab in that it attacks bad blood vessels, and they combined it with olaparib, the PARP inhibitor. And in smaller studies, they showed that the progression-free survival of the combination was better than either one alone. Unfortunately, when they looked at this combination compared to those platinum doublets that we talked about that are the standard of care, they didn't see a benefit in progression-free survival. However, they didn't see a negative either. So it would seem that this combination is probably just as good as chemo. Unfortunately, that's not the way the trial was designed. And so this currently is not an option for our patients, but it is something that's being explored further. Similarly, the AVA-NOVA trial was 2 drugs that have different names, but same mechanism, right? So niraparib, another PARP inhibitor, bevacizumab, you know, that's the bad blood vessel attacker. They put those 2 together compared to the PARP inhibitor alone, and they saw that it did improve progression-free survival, especially in this group down here in the bottom right corner that had no abnormalities in their tumor, no BRCA, no HRD. So this is a combination that's very exciting that is moving forward into bigger trials. So stay tuned, and hopefully this is something that's going to change practice. Now, finally, what about our population that has had multiple lines of therapy and their cancer came back in a very short window after their treatment or even during their treatment? That's the so-called platinum-resistant group. And really, it's for whom patients we don't think platinum is going to work out very well. So here's some of the data around single agent chemotherapies, and there's a number of trials that have been done. You can see this again, RR is that response rate, that's that shrinkage of disease. These numbers are okay. Some are low, right? Some are 10%. That's not enough. 10 women out of 100 responding to therapy, none of us are satisfied with that. Some are approaching that 30% mark. That's of course good, but really that progression-free survival, time without growth of cancer, only gets its best as about 6 months. And we all can agree that's not enough. And so there's a lot of interest in using combinations here and other kind of novel therapies to improve outcomes. The first is, again, our friend bevacizumab. You can see we use it in recurrence. We actually use it up front, and we can use it for patients for whom platinum is not an option. The Aurelia trial took standard chemo including topotecan, paclitaxel, and pegylated liposomal doxorubicin. And patients either got the chemo alone or they got the chemo plus the bevacizumab. And now you guys are experts on curves now. Nice difference, right? And really big improvement in progression-free survival for patients that got the combination. And importantly, we always worry, if we're giving more drug, are we making people sicker? The patient-reported outcomes asking about symptoms at baseline, including bloating, abdominal pain, nausea, they got better. They got better when they got the combination strategy. So even though there may be more side effects with the combination strategy, the patients felt better with that. So it improved their survival and it improved their symptoms. So check on that. This is absolutely a standard of care. We use this drug in combination with chemo all the time. Now, everybody in the audience, no doubt, wants to talk about immunotherapy. Okay, so immunotherapy is very different than what we talked about recently. We talked chemo, hits all the cells in the body. Targeted therapies like that bevacizumab and the PARP inhibitor target the tumor directly. Immunotherapy actually stimulates our own body's immune system to fight the cancer. It has been a home run in things like melanoma, lung cancer, bladder. For ovarian cancer, it's been okay. It hasn't been as bold of an impact as a single agent. So these are 4 different immunotherapies that have been explored on their own in ovarian cancer: atezolizumab, avelumab, nivolumab, and pembrolizumab. And again, they stimulate the body's immune system. Response rates have been around 11 to 15%. So again, 11 women out of 100. That's not good enough. So as a single agent, this is not something that you will see if you're getting your treatment for ovarian cancer. However, I'm going to show you some really exciting data looking at ways we can combine immunotherapy with other drugs, like we did with the chemo and the bevacizumab. Can we do better with combination over a drug alone? So the first study to do that, sorry, our mailman is here, so our dog is going to tell him for a minute. So the first trial to do that was the Javelin Ovarian Cohort Study, which combined pegylated, Trixie honey, give me a break, pegylated liposomal doxorubicin and avelumab. And that was a trial that looked at the single agents by themselves, avelumab, okay honey, please, pegylated liposomal doxorubicin, and the combination of the two. And it found there was a slight benefit to the combination over either one alone. It wasn't as bold as we hoped, but they did start teasing out a population for whom that combination might benefit. So that's being explored further. The NINJA study looked at the single agent nivolumab versus chemo in general, and the chemo included gemcitabine as well as pegylated liposomal doxorubicin. Again, single agent, it just didn't do enough, okay? So they didn't combine it together, they just did that single agent. It wasn't quite enough. However, when we took nivolumab and added another immune oncology agent, another immune stimulator called ipilimumab, that seemed to get us some improvement. We saw that the patients that were randomized to the combination of the 2 drugs had improved response rate, 30%, as well as an improvement in progression-free survival. So that's pretty exciting. And this combination is moving forward in larger studies to see who's the best patient population and where it should best be given. Now, we also have looked at combinations of immune oncology agents with different targeted agents. So you'll recognize niraparib as being, again, a PARP inhibitor. And the drug pembrolizumab is one of those checkpoint inhibitors, one of those immune oncology agents. And this was a paper presented by Dr. Konstantinopoulos from Dana-Farber that showed that the combination of the 2 had quite a bit of activity in patients that had platinum-resistant disease. So they had no more benefit from platinum. The majority of the patients, if you look at the little color scheme here, it's small, but it's doable. The dark blue means that the patient had a BRCA mutation. The lighter blue means that they had some type of HRD, right? So something to predict response to PARP. And the lightest blue means that they did not. They saw benefit, and you can see in this waterfall, again, we want things falling down, we want things shrinking. They had benefit in patients that had no BRCA mutation, no HRD in their tumor. So that was really exciting. Now this other plot, plot B, this is called a swimmer plot. So this is how long did the benefit last, right? Because if the benefit only lasts a couple of weeks, then that's not good enough. So these swimmer plots show us that not only did we get nice deep reduction in tumor, including 2 patients that had complete response, we also had durable, people approaching 120 weeks of therapy. That is obviously super, super exciting, over almost 2 years. And so this is a regimen that is moving forward. It's being looked at in the upfront setting as well as in the recurrent setting. Similarly, the Mediola trial combined olaparib, the PARP inhibitor, with a drug durvalumab, another one of those immuno-oncology agents. Now, their first study looked at BRCA mutated patients, okay? And they saw that the combination of the two had very, very good response rates, 72%. That's at the very least equivalent to chemo, maybe even better. And again, look at that swimmer plot down below. Patients staying on for more than 450 days, so over a year. Very, very exciting, will be explored further. But here's what I want to touch on. This is the combination of, again, olaparib and durvalumab, now with bevacizumab, in a patient population that does not have BRCA mutations. Ooh, we're seeing some really exciting treatment data here. We're seeing 70% response rate in a patient population that wouldn't even be expected to respond to platinum. So these kind of combinations are very exciting. Obviously, these are small studies. This is every line's a patient. So we're looking at, 20 patients or so. This is going to be explored in larger trials, but it is really where the research is going. Now, the last minute or two, I'm just going to talk about a completely novel type of drug called an antibody drug conjugate. And these have been had a big splash over the last couple of years. They're being explored against a number of different targets. So what does this antibody drug conjugate mean? Each of these is basically takes a target where something we know that is sitting on the cell surface. So if you look at this little picture with the blue, there are these little guys that stick out of the cell wall that different treatments can find. So you pick a target, and for this particular drug, mirvetuximab, it has a target of the folate receptor alpha, which is overexpressed in about probably 40 to 50% of patients with ovarian cancer. Okay, and this antibody finds the target. Now, antibodies basically are magnets, and they'll find the target and attach to the cancer cell. So attached to this antibody is a little tiny linker, and attached to the linker is this big payload. It's a huge, heavy dose of chemotherapy that I could not give you in your IV because it would make you too sick. But what it does is that antibody links to the cell and it pulls that chemotherapy in. It drags that big bomb of chemotherapy and it inside the cancer cell, killing the cancer cell, but not hurting you as bad. Hey, so I'm going to show you some of the data for mirvetuximab just over the next minute or so. So this was the drug being looked at in an early phase trial. So 46 patients, they did it in kind of an all-comers patient population, but they did only include patients with ovarian cancer because they were most excited about exploring that. And they saw a really exciting response rate, 26%, which is almost unheard of in a phase 1 trial. But when they teased out the population, which is in this little red box, that had a very high expression of folate receptor alpha, that's where they saw the biggest activity. Almost 50% of patients having shrinkage of disease and the progression-free survival approaching 6 to 7 months. Pretty awesome. So they went on with so-called Forward 1 trial, which compared this drug, the mirvetuximab, that big antibody drug conjugate against folate receptor alpha, and they compared it to, again, investigator's choice chemotherapy, paclitaxel, pegylated liposomal doxorubicin, topotecan. These are the usual suspects, right? And they looked at progression-free survival. And what they found is it didn't have as much benefit as they thought. Kind of were like, what happened? They looked at this group. You can see these curves lay on top of each other. There's no difference. They looked at the group that had really high expression of folate receptor, and they started to see a difference. And then they realized, oh my gosh, we changed the way we were judging folate receptor. And this is an important thing for patients because, we all want this personalized therapy. We want precision medicine. And we're only as good as the tests we use. So if we're checking your tumor for folate receptor alpha, but we're not checking it with the right test, we could be missing an opportunity. And that's exactly what they realized, is that they had tested it in a way that wasn't as relevant as it should have been. And so they went back and retested the patient's tumors with a much more precise look at folate receptor alpha. And what they found was in that population that really truly had high folate receptor alpha expression, there was a difference, more than a finger. There was a reduction in the risk of progression of about 50%. So that's no small thing. So they are moving that forward in a bigger trial to try to get this to you, the patient. But they're also looking at understanding that what we've seen over and over again, that single agents aren't always enough, right? We've showed that multiple times that, we see good responses, but it's not enough. So can we combine mirvetuximab with other agents? And look who they chose, bevacizumab, our friend. And so again, they took a population that had high folate receptor alpha expression, and they added bevacizumab to mirvetuximab. And this was just reported this year. Now, I know you guys are all experts now. You like this waterfall plot, don't you? Look at all that tumor reduction. We love this. And it was really across people that had both medium folate receptor alpha expression as well as high. And so the overall reduction in disease was almost 50%. So very, very exciting in this platinum-resistant population. But that little curve on the right with all purple, look at that. Almost every single patient that had high folate receptor alpha that got the combination of the mirvetuximab with bevacizumab had a reduction in their disease. Like, that is super exciting. 64% true shrinkage, and then an additional almost 30% that had stabilization of their disease. Really, really cool. And this little plot on the bottom is called a spider plot. It's very similar to our swimmer plot, but it's mapped in a different way. But again, you look to see how far out it goes. That's how long they were getting benefit. And you can see, again, patients were getting benefit for more than 400 days. So it works and it lasts. Very, very exciting. And this is getting explored further for patients right now. So in summary, I think that, I want you to walk away knowing we have a lot of really exciting options for patients that have recurrent ovarian cancer. And this is an area where tons of research is ongoing. So we know we're moving the needle and we're continuing to improve those curves and have people live longer with good quality of life. We do use that treatment-free interval to try to guide which option is the best for you, and are exploring those novel therapies that we talked about. Certainly the PARP inhibitors, the antibody drug conjugates are really exciting. Immunotherapy, probably still a work in progress, but we're starting to scratch the surface of who we might need to pair it with in order to get the best benefit. But really understanding what you need, which combination is right for you, is going to be really important moving forward. So not just kind of slapping two things together, but saying, okay, for you and your tumor, you should get this particular combination. So that's really what's moving forward and what's next on the docket for patients with ovarian cancer. So thank you all so much for your kind attention and so much for the invitation. I am just thrilled to be here, and I'm really looking forward to a lively discussion.
Thank you so much, Dr. Westin, for that incredibly informative presentation. So we're going to get started with the Q&A now. You can still submit questions in the question pane in the GoToWebinar control panel. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. So I'm going to, while people are starting to submit those questions, I'm going to get started with some of the questions that people submitted beforehand through registration. And so, of course, we talked a lot about PARP inhibitors, and one thing that comes up a lot for people is just sort of wondering, how long is it safe to be on a PARP inhibitor for maintenance?
Yeah, it's a great question. We're still collecting data around this. The main thing we worry about is the development of leukemias or myelodysplastic syndromes with long-term use. Now, we know that patients with ovarian cancer can develop these problems even if they're just treated with carboplatin. That has been demonstrated. What we're trying to understand is how PARP inhibitors might increase that risk or might put people at a higher risk of developing those things. What we know for recurrent ovarian cancer, the majority of the studies have been continue that PARP inhibitor until progression of disease. But what we see is initially that in the early studies, the risk of those leukemias and myelodysplastic syndromes was probably somewhere around 1 to 2%. However, in recent long-term data, it may be higher than that. So it's undergoing further assessment of, is there a point at which we should stop the PARP inhibitor to help reduce that risk? I will say that PARP inhibitors are getting used earlier and earlier for maintenance strategies, getting used in the front line, actually. And so those are definitely getting stopped after a set amount of time. So say 2 years or 3 years, depending on the drug. And I do think that will hopefully reduce our risk of developing those blood disorders.
Great. And so this question is about whether having a PDL1 mutation in your tumor, is that considered HRD?
Sure. So PDL1 is an abnormality that has been used to look for response to immunotherapy. And it's actually not a mutation, it's just looking at the expression of a protein in the tumor. And so it's not something genetic, it's something protein-based. And it's a test that's very easily done. It's done as part of a lot of molecular tests that you might get clinically. In certain types of tumors, like cervical cancer, for example, it can be used as a factor to determine if you should be treated with an immunotherapy. That has not been as well developed in patients with ovarian cancer. Now, there have been some smaller studies or some smaller assessments of larger studies that seem to indicate maybe PD-L1 expression could predict a better benefit to immunotherapy in ovarian cancer, but it's too soon to use that clinically. HRD is a test that looks at the ability of a PARP inhibitor to work in ovarian cancers, and specifically it looks at something called loss of heterozygosity. And so it's different from that PD-L1. So it's a different test, but it's something that's done on that tumor.
Okay. So this question is about what about TTF as a treatment option for clear cell chemoresistant?
So TTF is Tumor Treating Fields, and it's pretty early in its development. There's an ongoing trial right now, and in the interest of time, I couldn't cover everything, but it's being combined with chemotherapy. And it's this really cool contraption. You basically stick it on yourself, and it releases these electrical pulses. And they've done some research in lung and other cancers, and did see that when TTF was given in combination with chemo, it did show a benefit over chemotherapy alone. So there's a similar study ongoing now in ovarian cancer. That trial is actively enrolling. And so if you have an ovarian cancer that has been deemed platinum resistant, or that platinum is not going to benefit you, that's something that you definitely can consider enrolling on. But it's too soon to tell. Now, the specific question was around clear cell. The trial that's being done is an all-comer kind of high-grade ovarian cancer study. So it's including high-grade serous, high-grade endometrioid, as well as clear cell. So it's hard to say if that will be an option. Now, because someone asked a clear cell question, I will mention that immunotherapy may be an option in clear cell. Those single agent data that I showed you, where there wasn't that great of a response rate for patients with ovarian cancer, a few of the patients that got benefit were patients with clear cell tumors. So there's a real interest to make a trial or explore a trial just in clear cell with immunotherapy. So those are in development and ongoing. So it'll be exciting to see if that may be an option for our patients with clear cell tumors.
Great. And I do, since we got this question about clear cell, just want to make a quick plug that in March, Cher is going to have a webinar on rare ovarian cancers it's going to cover clear cell, so be on the lookout for that.
That's great.
So this is a good question, and I think especially because obviously so much of this data you presented comes from clinical trials, and so one person is asking, how can patients find out about clinical trials and get involved in some of these studies?
Well, I have a whole lecture on that, so I'd be glad to do that as a future webinar. And this is something that we've done at a couple of different survivor groups, because you're right, it can be so overwhelming to understand, what's available to you and how you get involved. The first thing is to ask your doctor, right? So many of us are very savvy to that and have options kind of available to you. But that's not always, sometimes you may be being treated at a place that doesn't have clinical trials because they don't have the infrastructure. You can ask your doctor to say, okay, who do you refer to? Is there some place that you send patients so they can explore options for clinical trials? Okay, so that's your first kind of point of contact. But there are a number of different websites that are, varying degrees of user friendliness for patients that you can do a search. And I will work to share some of those. And maybe, I don't know if there's an opportunity that we could send out those links. But for example, the Foundation for Women's Cancer, you can go on their website and it has a part that says find a clinical trial, and you can put in a little bit of information about yourself, where you are with your cancer journey, and they'll help you pull in options for therapy. Okay, and it's really cool because it has a link where you can say screen me, and they'll actually connect you with somebody that is involved in that trial, and they can tell you, oh yeah, that is an option for you, or that's not. Places like MD Anderson, where I work, we actually have a research navigator. So if you call us, we'll connect you to Liliana, who's amazing. Shout out to her, and she'll talk to you about where you are in your cancer journey and say, okay, we have these options for you. It used to be that meant you'd have to come all the way down to Houston, but now with virtual consults, we're able to see a lot of people like this over a video and talk about what options you might have. And then the last website I'll mention is clinicaltrials.gov, which is run by the National Institutes of Health. And it has a great search function. It can be overwhelming though, because when you first start with your search of ovarian cancer, let's say, you can pull up like thousands of studies. So there's different little ways to kind of reduce those searches down to get a better idea of what trials are really an option for you. But it does take a little bit of education to kind of know how to find that stuff.
Great, and we may take you up on that in the future about a clinical trial program.
I think it'd be super fun.
And so this question asks, do you need to have a fresh biopsy for FRA or other mutations? This person's genetic results are based on a tumor from 2015.
Yeah, we often do this, and the bottom line is it depends on the test. So it seems that certain things like the folate receptor alpha don't really change that much. We're still trying to understand. There's a lot of research ongoing in this space to say, okay, if you have your tumor, say, at baseline from 2015, and then we biopsy you in 2020, how much has your tumor changed? And for certain things, it doesn't seem like things change that much at all. For certain things, it may. So the homologous recombination deficiency types of things, that doesn't change. But its actual relevance to how well your tumor responds to PARP might change. And so this is an area of ongoing research. What I tell patients is, if it's been more than like 3 years or so, I'll usually do another biopsy just so we kind of have a fresh idea of what's going on in the tumor from a genetic standpoint. That's from that mutation standpoint. But for some of the protein tests and things like that, we don't.
Got it. Thank you. So this person is being treated with Lynparza to prevent a recurrence. And their doctor said they need to be on it for 2 years. Is this the standard, or are there any updates on this?
Yeah, so the upfront treatment, so if we are doing maintenance strategies for patients after they were just diagnosed and got surgery and chemotherapy and now being transitioned to a PARP inhibitor to keep the cancer away, for olaparib or Lynparza, as you mentioned, that is something that we would recommend for 2 years. And the studies are really good. We're still waiting for final data from that study, but they just reported 5 years out from their, from patients starting that maintenance. And you can see the patients stopped at 2 years and that survival benefit continues. And so it does seem that that's really reasonable in the upfront setting. In the recurrent setting, we just don't know, because all the trials really kept continuing the PARP inhibitor until the cancer came back. So what we don't know is really, do you have to do that, or could you stop? And I think there's a number of studies that are trying to start looking at that so we can better counsel patients and make sure we're not treating somebody for longer than they need to be treated.
Mm-hmm. So this question is about, so this person has a support group member who is struggling with a wait and watch approach, and is wondering if you can address when this is, makes sense to do.
Yeah, so things have changed a lot over the last few years as we've gotten a number of different FDA approvals. Most of this has been in the upfront setting, which is not what we talked about today. My dog's annoyed again. That population in the upfront setting, so it's after treatment, surgery and chemotherapy, used to be everyone just got watch and wait. We didn't have really any good maintenance strategies. Sometimes we would use that drug bevacizumab that we talked about in combination with chemo and continue it after. However, over the last few years, PARP inhibitors have been approved for patients that have BRCA mutations or for patients that have homologous recombination deficiency, and even that HRD test that we talked about, and even in all comers. So niraparib can be given to everybody. But what we see is the best benefit is in those patients that have the BRCA mutation. The next best is for those patients that have HRD. And kind of the least benefit, there might still be some, but the least benefit is for those patients treated with PARP inhibitors that don't have any abnormalities, don't have BRCA, don't have HRD. And so we do still use watch and wait for that population that doesn't have an abnormality that would predict response to therapy. And I'm assuming, I'm kind of playing a guess what I'm getting at kind of thing, but I'm assuming that's what the person was asking about. In the recurrent setting, it all just depends on the situation. It's a very complex decision about whether or not you should be treated with some type of maintenance strategy. We generally tend to kind of continue treatment if we're getting benefit and really avoid a watch and wait unless somebody is not really tolerating therapy really well or if there's a quality of life issue.
Mm-hmm. This person is asking whether maintenance is recommended after second-line therapy.
Yeah, so those are the curves we showed with the NOVA data, the SOLO2 data, and the Aerial 3 data, as well as the bevacizumab data. So the bottom line is, yes, I would strongly consider one of those maintenance options after second line. Now, some of the choice is going to be depending on what you've done with your chemo. So if you got your chemo on its own, we don't really start the bevacizumab just as maintenance. It's generally given with the chemo and then continued on its own. For PARP inhibitors, you can start that maintenance if you get a benefit from your chemo. So if you get shrinkage of disease or your disease goes completely away, that's really where that PARP inhibitor maintenance can be very helpful. And again, it's most helpful for the patients with BRCA, a little bit less for HRD, and still helpful, but not quite as much as BRCA in those patients that don't have an abnormality. But we do recommend giving it a shot because there are definitely patients that don't have any known abnormalities that get benefit from PARP. It's just trying to learn who they are. And so for my patients, it's something we talk about and we do recommend if they're up for it.
Mm-hmm. And I know we talked a lot about sort of different drug treatments, but I was wondering if you'd be able to talk at all about when a secondary cytoreductive surgery is indicated in the treatment of recurrent ovarian cancer.
Yeah, I mean, I focused a lot on the therapeutic side, but yes, I'm happy to talk about the surgery side. So there's a very specific patient population for whom surgery is a good option. Okay, what we know is, again, that treatment-free interval really matters, right? So how long have you gone without your treatment? And generally we use that treatment-free interval from the first treatment. So you got your surgery and chemo up front, maybe got a maintenance, maybe not. How long has it been before your cancer came back? So that's number one. The second thing is, how successful was your first surgery? Were they able to remove all of the tumor at the time of your first surgery? Because that does predict our ability to do that again, okay? And then the third thing we look at is how many sites of disease are there? So how many places has the cancer come back? Because we know in the second line or in third line, if the cancer is in multiple places, that our chance of you getting a benefit from surgery is much, much lower. So we want to see either a single site of disease or maybe two sites, not that many sites of disease. And there's been some conflicting data on this, but it does seem that when patients are appropriately selected, then they can get a benefit from surgery. But we need to achieve our surgical goal, and the surgical goal is to get all the cancer gone. So those factors that I just mentioned, the sites of disease, how long it's been, those all predict our chances of getting you to no evidence of disease again. And so that's how we make the decision of if surgery is a good option in the recurrent setting.
Great, thank you. And thank you for such an informative program and for answering all these questions. That's all the time we have for today. You know, this was a great program and we covered so much ground. So thanks to you, Dr. Westin, and thank you for everyone to participating and submitting your questions. Please take a moment to fill out the survey at the end of the webinar. It may take a minute for the survey to download after the webinar shuts down.
All right, thank you so much.
Thank you.